Start our recording. Perfect. Thank you. So welcome. For those of you that do not know me, my name is Shamia or Mia. I am viral hepatitis program director, acting program director with the Tennessee Department of Health, and I will be your facilitator for this session. So looking at today's agenda, we will start with introductions and a brief announcement, and then we will go into our didactic presentation with Dr. Alfaro Cruz, talking more about monitoring actually for children. This time we talked about recommendations last. So then we will do one adult case presentation and a pediatric case presentation before going into questions and answers and some hot topics as well. If everyone can get started, though, we'll take just a couple minutes and pause here to begin registration with Southeast Age Education and Training Center if you haven't already. Not only are they kind enough to help with making sure that we can offer continuing education, but they offer a lot of additional materials related to HIV, viral hepatitis, as well as others. So we will put that link in the chat for you. As you can also use the QR code as well. Let me see if I can get it to paste. Just one moment while I get the link for this event. All right, I think I got it in the chat for you. So we'll pause just for a second while we have folks get signed up. If it's your first time registering, it'll take just a moment to fill out your profile, but then after that, all of your information will stay in your dashboard, and it's pretty quick just to add in your which sessions you want to go to. And they do lots of other webinars and such as well. So awesome to check out. All right. While others are continuing with that, we can get started with introductions. So if you will, introduce yourself in the chat. Take a second to add your name, role, organization, and whether or not this is your first ECHO session. We're really excited to get started and welcoming everyone. I see a couple people already putting their introductions into the chat. And some familiar faces too. And it looks like Dr. Alfaro Cruz is back, so just in time, really. So today we will be talking about monitoring children with hepatitis C. Dr. Alfaro Cruz, do you feel ready?
Let's do it.
All right, passing it off to you.
Hi, good afternoon, everyone. Thank you for joining us on actually this hot Wednesday. Hopefully fall is coming soon and we can start enjoying some cool weather. Today we're going to talk about in the series of children's and hepatitis C, what about monitoring children who have hep C? We have always talked about what we do at the time when we diagnose them, how long we have to wait until we treat them, but we have truly never discussed what to do in that in-between time or in that transition period where we know that we have a diagnosis, but we cannot still treat it. Next slide, please. I have no financial disclosures or conflicts of interest to report. Next slide, please. So as we talked on our last session, we know Hep C, it's important. And we know that we are doing these ECHO talks because we want to bring the message across our all providers and all healthcare providers in the state of Tennessee. We know that there's 115 million people infected in the world. 11 million of those are actually less than 15 years of age. Chronic Hep C infection has actually been associated with severe liver disease and other complications that can increase morbidity and mortality. Just alone in the US, within the years of 2010 to 2020, we were thinking that health costs were close to between 200 and $336 million. And then, of course, the emotional burden of having to deal with this diagnosis and the complications or the consequences are more difficult to estimate. Next slide, please. We also have been discussing how most of symptoms and signs of Hep C infection in children are asymptomatic. Don't expect that a child is going to have severe symptoms or being significantly sick when most of the times kids are usually asymptomatic. Liver disease is uncommon during childhood, but it has occurred. We know that it can take years until their Hep C chronic infection can lead to severe liver dysfunction. But we have seen some cases, and usually less than 1%, that can actually advance rapidly into Hep cirrhosis. The thought process, too, is that we are seeing more obesity in our children's. And so that can get to a more injury to the liver associated with fatty liver. Now, remember, cirrhosis and fibrosis can occur, but that is not the gold standard of what we see. And a lot of the times, kids can present with just some elevated liver enzymes that they were getting on routine tests, and that's how kind of can lead to a diagnosis of Hep C. Next slide, please. So we talked, who do we screen? Who do we screen for Hep C? And this is important because this is going to lead us to the point where we are monitoring our children. So we know that we screen any child with clinical evidence of hepatitis. That means that they have elevation in AST and ALT. Infants that are born to a birthing parent that was infected with Hep C and has an active Hep C infection. Siblings of those parents or siblings of those infants that were born to a mom that was infected with Hep C, any international adoptees or refugees, and we have discussed this in our previous session, whether in the US is standard that during prenatal care, we're going to check for Hep C. But a lot of, especially third world countries or underdeveloped countries, they may not actually be screening for Hep C. So this is important to know anytime that you have an international adoptee or refugee coming into established care about potentially screening for that patient. If we have children and adolescents with HIV infections, anyone who has been sexually assaulted too will actually require a screening. And if there is a concern or suspicious for illicit drug use, especially IV drug use. Next slide, please. So currently, and this is actually from coming from the CDC and the Department of Health, Tennessee Department of Health, we are actually monitoring or we're actually screening kids between 2 and 6 months of age. We're using Hep C PCR RNA, and we try to get these as soon as possible when they come in our appointment. And that's what we're trying, primary care providers, healthcare providers, to actually start screening sooner. That way we can actually catch this kid and follow him through the period of time until he is able to receive treatment. Now, if the baby comes between 7 and 17 months and they have not been previously tested, we will still obtain a Hep C PCR RNA. If the kid that comes and it's more than 18 months of age and has not been previously tested, then we are actually going to get a Hep C antibody testing with reflex to the Hep C PCR RNA. Most of the institutions will send that Hep C antibody, and it will, in some cases, automatically reflex to that Hep C PCR RNA. In the case where your institution does not reflex automatically, then the indication is as soon as you get that Hep C antibody, to obtain a second test to check for the Hep C PCR RNA. Next slide, please. So what do we do? So what happens when that child that was screened comes back and tests positive? So according to AAP guidelines, we want to continue providing normal health care to that child. We will continue with his regular well child care visits per AAP recommendation. And this is kind of just to show you exactly what we do in the state of Tennessee, where usually if you are talking about diagnosing that kid between 2 months and 17 months of age, they will continue to follow up the standard care with well child care visits at 2 months, 4 months, 6 months, 9 months, a year, 15 and 18 months. If you are diagnosing that kid after 18 months of age, then they will continue with their yearly physicals or well child, usually at 2 and 3 years of age. Now, most of the time, and this is what that's important part to actually talk about it, we are talking about monitoring those kids who we know that we are not going to be able to treat right away. Most of the time, if you have a child that is older than 3 years of age and they come in for a visit and you screen them and it's positive for Hep C, we do have treatments now approved by the FDA that are going to let us treat as soon as we get that confirmation result. And so in that case, a 3-year-old that comes to your clinic then can actually be treated right away without any time frame that he has to wait. Now, in cases where, of course, we're actually aiming to start screening sooner, between 2 months and actually 35 months, then those are the kids that you're going to have to monitor because we don't have currently approved medication to start treatment at younger age than 3. So that's what's making it important over what are we going to do from the moment they get screened, testing positive, till the age of 3 when we can treat them. Now, remember, this is just following your regular well child care visits. The goal is not to impose or to get more appointments onto the family, but actually to help them getting into the care so we can continue monitoring closely. Next slide, please. So what happens when they come? So you have a child that usually has been diagnosed. So in that case, we recommend getting routine liver biochemistry at the initial diagnosis and then at least every year until the child is able to be treated. In this case, we usually recommend checking ALT, AST, or a CMP panel that will include ALT and AST and a total bilirubin. These are just gonna let us assess if there is any disease progression ongoing over the following until we're able to treat. And as I'm telling you, we're not expecting to get these labs every time they come for an appointment, but every year since they were diagnosed. Next slide, please. Another important thing that we actually recommend in between diagnosis and treatment is that that kid actually receives all the vaccinations. There is no contraindication for receiving any of the vaccines if a child has been diagnosed with Hep C. And in fact, we want to make sure he's up to date on his Hep B vaccine as well as Hep A vaccine, because the goal is to make sure we prevent any of these infections that can actually co-infect and worsen or progress liver disease. So we are following, as the state of Tennessee, the CDC guidelines, CDC and AAP guidelines regarding vaccination. And so that's going to be a very important thing to discuss with the family regarding keeping all his vaccinations up to date. And the most important in this case, Hep B and Hep A. Next slide, please. So by the time we're getting close to that age 3, we need to actually repeat and confirm that the patient still has a Hep C infection. As we have discussed in the past, sometimes they can clear the infection, but most of the time, if we get to 3 years of age and they have not cleared the infection, less likely that's going to happen. So if that's the case, we actually, by the time they get to 3, we're asking to be retested with a Hep C PCR RNA before we actually are able to start treatment. And at that time, we can also get a genotype that in most occasions will be required to get approval to start treatment. And that will actually be repeated at the age of 3. Next slide, please. So the other question is, do we need to actually do serial testing for Hep C virus RNA in a kid who has been diagnosed at 2 months of age, 4 months, or 6 months, and we are waiting to get to that age 3? So not always requires, but there are exceptions to this rule. When you check your liver enzymes, if you notice that there is a significant revert to normal in a kid that is older than 12 months, in that case, it can be advised to actually repeat a Hep C RNA PCR to actually see if the patient has spontaneously cleared the infection. Or if treatment is being considered and that child has reached the age of 3, then we need to make sure to confirm that he has active Hep C before even proceeding with treatment. And so these are the 2 exceptions to the rules. Now, some people will ask, what happens if his liver enzymes have always been normal? Then that is not an indication, and we would have to wait until he's reaching the age of 3 to repeat the testing and see if he has cleared or has not cleared the infection. Next slide, please. And most important, and you're going to see always this in my slides, it's educate, educate, educate. Because during the period between actually getting diagnosed and getting treated, a lot of the parents will be afraid about, how do we do it? Can he goes to daycare? Can he goes to school? Can he play with his siblings? Can he play with cousins or family? Can he go to activities? And the answer is always yes. We've always talked about educating our parents, and I think that's very important, about letting them understand that the child does not pose a significant risk to any other child or any other adults, that he can participate in school, in sports, in activities, that he can continue on regular childhood activities without any restrictions. And that everyone, parents or anyone who is in contact with the child, should just follow universal precautions in case there are some blood exposure in order to avoid infection, right? And of course, we always say do not share toothbrushes, razors, nail clippers, and always use bleach and gloves if there has been any blood spill up. But the most important thing is to make sure parents understand that this is not something that they need to actually isolate the kid and not expose him to other activities, as he is posing as a very low risk for other people. Next slide, please. Okay.
Thank you, Dr. Alfaro Cruz. It's encouraging to hear that there's not a lot of additional monitoring that really needs to take place from that kind of first testing and trying to keep the client in care until they are 3 years old. But one question we have here in the chat, and others, please feel free to ask questions as well. Come off of mute, add them to the chat, whatever works for you. So the first question is, do pediatricians often monitor AST and ALT levels, or do parents need to ask for them to check these levels?
No, so usually it all depends, to be honest. So in some cases, when in their well childs, most of the time, we do not check AST or ALT levels. There are some ages, especially in kids who are overweight, where we are checking like lipid screening, and we can actually get AST and ALT level because we're screening for fatty liver. But usually it's not something that pediatricians will often monitor. Now, and in cases where the patient comes in for a sick appointment, and they obtain blood work, and they notice that a CBC and a CMP and AST and ALT are elevated, that's when usually it will either kind of raise a red flag of why this kid has an AST and ALT elevated, and that can actually lead to the screening for Hep C. But otherwise, it's only until they get around 12 or the teenage years, or if they're obese, where the pediatricians will get AST and ALT levels.
So the difference is really if you know an infant has been exposed to hepatitis C, making sure that you're not only doing the hepatitis C screening, but some of those expected kind of baseline blood work and such, it sounds like.
Yes. So it's different when we already know that that child has been exposed in utero, because that's the one that we know we're going to monitor, versus just a normal child who we don't know about any exposures. We usually are not screening for AST or ALT.
Really helpful. And I did put the links to some of the graphics that were included in the slides into the chat for those that might be interested. Any other questions related to this presentation?
Now, I think, something it's very important to be aware is that we're only monitoring those who we not treat right away. Most of the time, if the diagnosis has been done after age 3 or after 3 years old, then we can definitely proceed and treat. We're not going to delay treatment. There are certain conditions where you may not be able to treat right away, but those are in cases where there may be cirrhosis, decompensated cirrhosis, and we have to do further workup. But usually we don't tend to see that in children. So from that case scenario, we don't want to delay from age 3 and above. We want to go ahead and treat right away.
Thank you for clarifying. Um, really helpful. So we'll take an echo pause and see if there are any other questions or comments before we move into our next piece. Okay, we'll move. Let's see. How do young children receive medications, ones that are not capable of swallowing pills?
Well, actually, we have presentation. All the medications right now have a presentation of pellets, and so that is how we are actually prescribing the medications, the Clusa, Harmony, to our patients who cannot swallow pills. We're giving them the little pellets. They can mix sometimes with applesauce or chocolate sauce or their preference, and that's how we're providing the youngest ones that cannot swallow pill.
Yes, really exciting to be able to offer treatment early on in childhood. So thank you. All right, in the interest of time, we will move into our hot topics. Are there any questions related to viral hepatitis that anyone would like to ask before we do our couple of case presentations? And these can be questions